We can get started. Good morning, everyone. It's a pleasure to be here with you. I'm Maite Vera. I am going to be the moderator of this webinar, web seminar, faith-based actors as promoters of vaccination. I would like to thank all of our colleagues who are collaborating with us throughout Latin America and the Caribbean from faith-based organizations. I'm sure you've all received our agenda full of presentations, and hopefully you will feel free to ask your questions. You can put your questions in the chat or the Q&A, question and answer tab. We have interpretation in Spanish, Portuguese, English, and French. And to access interpretation, you can just click on the globe at the bottom of the platform. We're going to hear from Dr. Salas, from Pajo, from the Health Promotion and Life Course Department, who's going to give us some opening remarks. Thank you, Maite, and a warm welcome to everyone who's here with us. On behalf of the Pan American Health Organization, I'm pleased to welcome everyone to this webinar. We'll be speaking with religious leaders and actors about what influence their roles have as advocates and promoters of vaccination, which is necessary for us to keep up the public health for many decades to come. I'm Dr. Saniel Salas from the Family and Life Course Department of the Pan American Health Organization. It's a pleasure for me to be with you here today, along with our partners, faith-based organizations. I don't know if everyone is fully aware, but in the Americas, we have achieved a lot, extraordinary goals. We have become pioneers. We have become a beacon of achievements. We were, before other regions of the world, to meet certain vaccination milestones and the elimination of certain diseases. We've reined in the transmission of very serious diseases such as measles, polio. And we have done this with very strong coverage that we have increased over time, that has especially benefited children and adolescents. And they always are waiting to see what we're going to do with our vaccination programs and other health programs to look out for their health. And at this point in time, we're in the second to the last place. After having been holding the first place, we are the second to the last among the WHO regions. Now, in 2021, 2.7 million children, boys and girls, who have not been vaccinated, or they do not have a complete vaccination, their full set of vaccinations have not been given. Before that, we were at 2.3 million behind, and so we're falling behind. We're leaving a trail of children behind us who have not been vaccinated, who are now at risk of getting polio, that will give them lifelong paralysis, or measles, children who are exposed to, or pneumonia rather, children who can get congenital conditions that could be avoided with a vaccine. And so this data tells us that the region is experiencing a resurgence of diseases that had been overcome, and the diseases now are knocking at our door. And this is a call to action to protect ourselves, to protect our communities, our loved ones. And so we call in this meeting upon the religious leaders, faith-based leaders throughout the region, to join the efforts that are underway throughout the region to roll out vaccinations. We need to come up with a very to the point, very timely, very clear message that conveys information that is something that any community can relate to, that is important and understandable, relevant to all communities, to raise this awareness and to instill trust in vaccines. Now, we have been a bastion in the region. Our region has been a bastion of vaccination in the region, but in the world, but we have to make up for lost territory because there are many children or generations who have never had measles or polio or diphtheria. And it's very important to take note of this because now we have to work on getting out the message of what we have avoided because of prior vaccination efforts. PAHO, WHO, is offering support to member states to ensure people have sustainable, timely access to vaccination according to principles of equity. And today, we are going to continue doing so through these different venues for dialogue between the public and religious organizations, and to drive home the message that we want there to be spiritual, physical well-being. This is something we have to do our best to ensure always exists. Faith-based actors have an important role to play in this process. Now, we thank religions for peace and everyone else who's taken part in this very important webinar. There is no doubt that the cooperation between public health and faith-based organizations is very important to bring people together in a spirit of respect in these different venues. The religious organizations have a very close relationship with the community, and they hold the community's trust, and that means that they are well positioned. They are ideally positioned to help overcome gaps in science, close the gap between science and faith. We're all affected by this. It's not just about me vaccinating my child, I'm protecting my child, but by so doing, I'm also protecting other members of the community who may also be exposed to these pathogens, viruses, bacteria that can wreak so much havoc in public health. Now, to look deeper into these topics, the Grand Rabbi Isaac will be speaking with us. Elias, we're going to look at the different opportunities to promote vaccination from religion, and it's also a pleasure for me to have with us from the health ministry. We're going to hear about collaboration with faith actors to promote cooperation, in this particular case in Guatemala. We hope that this dialogue will give us an idea of what the support can be offered by religious leaders throughout the region to encourage people to become vaccinated and to understand that faith-based organizations can be promoters for vaccination in their communities, such that we can all contribute to greater vaccine coverage. So I thank you all very much for being here. We're here to collaborate, and we will continue to do so as we've always done. And we just want to avoid resurgent diseases, and by leaning on each other, especially on, in this case, the religious organizations. Thank you very much, Doctor, for your words and for setting the context for why we are here. Now I'd like to introduce Mr. Elias Cisnicki of the Regional General Secretariat of Religion for Peace of Latin American Caribbean. He has some opening words for us. Elias, you have the floor. Good morning, everyone. I thank Dr. Salas for having organized this event and convened us. I thank Maite and the whole team that works in immunization at PAHO. Now, as we said in our concept note, that was sent out with invitation to this webinar, Religions for Peace International, a few months ago, signed a memorandum of understanding with the World Health Organization, and we see this activity as just the first step toward implementing this global partnership, this global alliance regionally between PAHO, the Americas, WHO organization, and Religions for Peace, Latin America and the Caribbean. Now, this seminar, as well as all the work that we've been doing thus far to promote public health, is also a part of our global objectives, sustainable development, the strategic plan on which Religions for the Peace has been working ever since our last World Assembly in 2019. The Sustainable Development Goals as well, of which there are 17, health being one of them, especially in our region. Our priority is to reduce inequalities as a cross-cutting agenda. And when we speak of SDG 3, we can't overlook SDG 3B for the production of vaccines, and no one at the time that was thought up in 2015, 2014, when the SDGs were drafted. No one thought back then that we would be hit by the COVID-19 pandemic a few years later, and all the attendant difficulties that brought to countries in the region. And many countries had a hard time finding the necessary inputs to either create or have access to vaccines. And we, as religious leaders, as we said on a number of occasions throughout the pandemic, underscoring vaccination as an essential human right and demanding that patents could be licensed freely or broken, so to speak, to ensure universal access to vaccines. Now that, thank goodness, the pandemic is subsiding, at least in our region, we see clearly how vaccines have made all the difference, enabling us to finally be at the stage we find ourselves in now, in which the pandemic has receded considerably. Now, the key messages that we will hear today from Rabbi Isaac and others is not just going to be here on this seminar, it's going to be disseminated. Now, we're going to hear from Guatemala about the Guatemalan chapter of Religions for the Peace and what Guatemala has done working on those diseases of greatest concern to PAHO. After this brief introduction, I just want to reiterate my thank you, and I would ask now Maite to give the floor to our panelist. Thank you, Elias. I thank you for being here. Now I'd like to give the floor to Dr. Lucia Oliveira, who is regional. She's from the immunization unit at PAHO at the headquarters, and she's going to tell us a little bit about what's taking place in the regional vaccination immunization program and some of the activities that have been carried out here at PAHO to expand vaccination and to flesh out a little bit what we heard in the introductory remarks by Dr. Salas. Thank you. Good morning. It's a huge pleasure for me to be here and to present to you a little bit of the technical aspect of the immunization program. And what I'm going to be presenting to you, I'm going to share my screen. Translating into slides or charts. Can you see my screen? It's not in presentation mode. Here we go. Now it is. In the next couple of minutes, I'm going to talk about the immunization program in the Americas. This presentation has some main topics, the overview of the regional immunization program in the Americas, the COVID-19 pandemic and its current state of play in the region, as well as vaccination efforts, PAHO's efforts to drive up the demand for vaccines and gaps that are still open, and what we can do to close those gaps, find solutions for them. Now, on the program, what I'm going to show you right here, translating into a chart, what Dr. Salas just said in his opening remarks when he said that in 2021, 2.7 million children under 1 year old, nearly 20%, have not received all of their vaccines. That means that these children are susceptible to diseases such as polio, tetanus, measles, diphtheria, rubella, and this goes back to 2000 through 2021 throughout the different regions of WHO, and pink is the Americas. Now, going back to 2000, you can see how over time our vaccination coverage has been dropping, so much so that by 2021, only 80%, we only have 80% basic vaccination coverage. Now, that compared with other regions of the world, the only region that's worse off than ours is Africa. All the other regions have better levels of coverage, and that was not where we were in 2010, in which we were at an entirely different level. So compared to the regions, we as the region of the Americas have been dropping off. Our coverage has dropped off much more than the other countries. Now, here you can see the different coverage from 2016 to 2021, according to the different diseases, BCG, hepatitis, rotavirus, pneumococcal, measles 1 and 2. You can see that all of the vaccines had higher levels of coverage in 2016, and all of them have dropped off. There's not one vaccine that is at the same level as it was in 2016. And this is truly a disaster for our communities and for our children. This chart is quite interesting. It also has to do with vaccination coverage, but what it shows is how large countries such as Brazil and Mexico are the countries that account for the largest drop-off in the level of vaccination. So what we see here is the number of children with no, having received no doses. Brazil is responsible for 38% of those children that have not received any vaccinations, Mexico at 17%. And you can look at each one of the countries in the region to see their current situation. This, of course, is a function of the population of each country. And when we do the same analysis with children that have not received all of their vaccinations, you can see Brazil leads the pack again, followed by the US, Argentina, Venezuela, Peru, Colombia, Bolivia, Ecuador, and so on. So this is a very sad situation because we know what this means. It's not just, these aren't just numbers, these are children who have not been vaccinated, and because of that might die or might get diseases, very serious diseases, leaving lasting negative effects on them. COVID. Now, today we have in our region more than 179 million cases of COVID that have been reported in the region of the Americas. 2,843,000 deaths from COVID from the beginning of the pandemic.
Now, as to vaccination, and as we all know, this began a year later. And this was once the pandemic set in. And here we're moving along well if we compare ourselves to other regions. Here we have 70.1% of the population vaccinated in Latin America and the Caribbean. And we also have this data from the WHO, and certainly we wanted to reach the minimum of 70%. And this means that 2 billion vaccines were applied. And we still have a number unvaccinated that represent 211 million. And this is the 30% missing. And if we compare this to other regions and to the situation that the children are facing in terms of COVID vaccination, the region is moving ahead relatively well. Not perfect, but relatively well. Nevertheless, when we break it down by country, and here we have complete vaccination per 100, and here we want to get to 70%, which is our goal. So if we look at it country by country and 70% rates, here we have the first countries. I can't name them all, but we have a number of countries that have reached 70% and a number of countries that have not reached 70%. And some from here on did not even reach a coverage of 40%, which was the initial goal of the region for COVID vaccination coverage. If as a region, we have 70% coverage, which is what we hope to reach, when we see this, in addition to the country breakdown, we don't see the same situation. We have countries here, such as Chile, Cuba, that have almost a 90% coverage, including the Cayman Islands. And here we have Puerto Rico with a very high rate, as well as most of the Caribbean countries. Now, this is important for when we talk about vaccination coverage. Now, the country numbers come from the region, but we need to confront the reality when we begin to break down the numbers, and we need to see, for instance, what occurs per country, even per state or per department or city within the country. This is very important. This is very important for each community, each city, each state, each department. And there needs to be an analysis done individually and not just look at the whole number or the regional number, because we need to see precisely where the problems lie, where greater efforts are required. Now, this is a bit what I was talking about. Here we have a review by sub-region on one side, and then we also have income levels. And here we have the Southern Cone, a sub-region of our region where we have better coverage. And we have the Andean region, and we have North America, Central America, and Latin Caribbean and non-Latin Caribbean, the English-speaking Caribbean. where there's a lower level of vaccination. Now, it's very important to break down the data. And when we do this, we can identify the factors that are the cause for a lower coverage. Here we have income levels. We can see that the high income countries and their coverage followed by middle income countries. And then we have lower incomes. And then we have the ones that are below the high income level countries. And then the unclassified countries at the very bottom. It's very important to do these analyses, but at the level of an immunization program, we do many other analyses in order to identify where the greatest problems lie. Now, what is PAHO doing to better the situation in identifying these problems? And to have you all as partners in this. We've undertaken many training sessions, technical orientation. We've provided a good deal of scientific material in order to strengthen communication on risk and also to achieve community participation. We also have national plans for risk communication and crisis communication so that the countries know how to confront a problem. For instance, when there's an adverse event related to a vaccination, and then it's all published in the media. And so then everyone believes that it's the vaccine that is responsible for whatever is happening. And this becomes an emergency situation for the countries in order to respond to this communication crisis. We also have social media and social networks to counter the disinformation on COVID-19 vaccines and to make sure that what's being promoted is based on solid scientific evidence. Very often the social networks can help us, but very often they also create problems, disseminating disinformation, reaching thousands and millions in 2 or 3 minutes. We're also broadening the presence of PAHO with social networks with more than 2,000 digital materials, which are produced in several languages. We also have a weekly broadcast of more than 100 communiques or press releases to remind the public of recommendations on COVID-19 and vaccination. And here we hope to counter all fake news. We also have a commitment to civil society because we think that they're more reliable in terms of communicating information within their communities. Now, the lessons learned, and we have many lessons learned. And here I believe that what we've learned in recent years, when this problem regarding information ballooned, especially with rapid communication in 3 minutes, millions of people receive information through a social network, and often it is misinformation. So as lessons learned, we understand that we need to be clear, simple, and timely. And we must never forget the cultural context. What happens in one country or the way it's experienced is not the same as in another. The same as language isn't the same in one country or another. So we need to adapt our communication. And we also need to involve religious leaders, indigenous leaders, and those who have an influence. This is very important because there are many of us who are working in the area. We also need to facilitate partnerships with the ministries of health and community partners, as well as the private sector, in order to join resources. We need to work with the journalists in order to see what we do with the myths and disinformation and make sure that everyone plays a role and can play a role in educating the public. Each and every one of us has a role to play when it comes to educating the public, not only in regard to vaccination. So this is very important that we keep in mind this role that we can play. We need to make sure that fake news is not propagated. I need to educate the people I reach, or at least I can communicate or transmit the truth based on evidence and data and what we've been learning from scientific evidence. We need to consider places where people come together and look at certain target groups in churches, in synagogues, where people congregate, in town squares, in theaters, in movie theaters. We need to find those spaces where people meet. And this is where we need to provide the information. They may not look for us, but we need to look for them. We need to carefully choose the spokespersons who speak about vaccination. This is somebody who needs to know what is being said and needs to know how to respond to questions, especially if the person is confronted with difficult questions or with fake news. We need to promote a very relaxed environment, and we need to make sure that people feel comfortable at community events, that they are speaking among friends, and that we are helping. We need to make sure that we have language and schedules that are appropriate for the target population. Now, maybe there are groups that we can reach at 8 in the evening, but maybe we need to reach some Saturday morning, but maybe not. But maybe we're not going to be able to reach them at 10 o'clock Monday morning. This is when everyone's going off to work. So we need to organize our communication on a schedule which is accessible to those who are going to listen. And this is what we need to do. We also need to make sure we have qualitative studies as well as focal groups in order to better understand specific opinions. And this is what we've been working on, because very often as scientists, we believe we know everything, and we do not know everything. We only know a part of what's in front of us, but we need to better understand what the requirements of the population are, what their problems are, and how they better understand or what their perspective is, what their point of view is. If we don't know what the point of view of the population is with whom we're working, we won't be able to act. Because the simple fact that I am a doctor and I am talking about what I think and what I know, this is not enough. And it may have zero impact. Very well. To conclude, what are the gaps still before us? There's still a lack of trust regarding the safety and effectiveness of the vaccine. For instance, COVID was a very clear example of this because the vaccine was developed over a very short period. And we know that there were certain events that occurred, and we know that the public then becomes very skeptical, but they need to know how the vaccine is manufactured. And some of them will say it causes autism, or it does this, or it does that, and we need to counter this disinformation. We also need to see what the serious side effects are and what occurs over the long term, what happens in 10 years. And people also ask these questions. Now, why should I receive a vaccine if I can still get sick? Many felt that they were going to be immune to the disease. And they realize that they can still become sick. And so they asked, why should I become vaccinated? Now, we do know that the seriousness of COVID is much greater if unvaccinated. And we need to find ways of communicating this so that it is fully understood. A lack of trust in authorities. Very often, people do not trust their governments. And so they believe it is something political and not a question of public health. And we need to work with this reality because disinformation, when the pandemic began, when COVID began, the WHO director said, we have two pandemics. We have COVID and we have the infodemic. Never have we seen so much information disseminated simultaneously in all countries at the same time. Very often it was accurate and educational information, but all too often it was misinformation. There's also the spread of rumors through the social networks. And very unfortunately, many groups, many anti-vaccine groups, which are increasing in our country, are based on much of what we're talked about. And these groups are becoming stronger. So we need to know how we can deal with this situation. Not easy. And also personal reasons. There are those who, for religious or cultural reasons, do not want to be vaccinated or their children to be vaccinated and do not accept vaccination. So I believe that with this, I close. Thank you very much. Maite, over to you. Let me turn off my audio. Thank you very much. Thank you, Lucia. Are there any questions for Dr. Lucia? Could you please put your question on the Q&A, which you will find at the bottom of the app. Very interesting to see the situation in the region and what PAHO has been doing in recent years and what it will continue to do in coming years to make sure that there is increased vaccination coverage and that all children are protected when it comes to preventable diseases. Now, I would like to give the floor to the Grand Rabbi of Buenos Aires, Isaac Saka, and he's going to talk to us about why vaccination is a religious duty. Thank you very much, Rabbi, for being with us today. Good morning and thank you. And my congratulations to all of the organizers and participants of this very important meeting, the goal of which is to benefit the world, to promote health of human beings, and to counter certain mistaken beliefs. And all too often, these are attributed to religion or faith. Now, the importance of the idea that you've had to bring in religion and health and vaccination is very important. Because historically, there's been a prejudice, a conflict in terms of natural laws and religion. Now, human beings have evolved. When there was a lack of information, and very often magical or mystical explanations were given, which had nothing to do with reality. So what was being sought was an answer, a cure. Given these magical or mystical beliefs, which basically went against natural laws. The laws created by God himself. This went against the natural laws of the planet of creation. And this created a malaise. This led to idolatry in the past. Those who believed in something that had no scientific or rational explanation. Now, with the advent of the word of God and the belief in this, we see God revealed to mankind, guiding a path towards good. Now, the first chapter of the Bible, this is the basic text of all of the Abrahamic religions. It begins with creation, the creation of the universe. It's nothing more than the description of having God create a world with natural laws. These will be moderated and model the life of the human being. The word of God itself. In that year, 2448, was telling mankind, do not believe in paganism's foolishness or anything that is beyond logic. And so let's look at how the world is created. It has an order, it has a system, it has a mechanism. And what you need to do is adapt to this mechanism and also protect this mechanism. And there is a saying in Hebrew, we need to protect the world and we need to become partners in protecting the world and respect the will of God. And this is respecting the creation of God. And this means taking care of nature, taking care of living beings. We're among them, the living beings, but we need to care for life. If there's a God, there is life, and we must protect life. And there was a great Spanish Jewish philosopher who also said that to serve God, we need to have life. And to have life, we need good health. And health is something that comes before all religions. For instance, the most sacred day in the Jewish calendar is Yom Kippur. And here, what is said is that if a person for health reasons cannot fast, this person is not allowed to fast. So in all religions, what we see is a fundamental respect for life. If there's no life, there's no religion, there's no serving God. How can we serve God? How can we serve our neighbors if we are unwell? So Maimonides did right. He made up a compendium for work and health. We're talking about the year 1100. And it was necessary to struggle against prejudices. Sometimes one thinks that there's insufficient faith when one protects health. We need to protect health, and God supports the progress of man. If we have agriculture, we need to prepare the fields, we need to sow them. Now, if we build a temple, we need to respect the laws of architecture. This is all part of God's creation. And with all of this, when we take into account science and we take into account common sense, we are better and can do more good and serve God and serve our neighbors. This is very important because we are often influenced by paganism, which leads us to think that religion goes against common sense, against natural science or professionalism. It's quite the opposite. God does not arise unless there is life, and life is to be protected. This is a basic tenet of religion, and life is the choice. We cannot think. The Talmud says, everyone who saves a life is saving the entire world. And what is saving life? It's not praying, it's going in and helping, it's going in and vaccinating. It's having the physicians go in where there is no access to care. This is protecting life. Now, this is one of the important aspects of religion. That religion goes against anything that threatens health, but rather there's also a mandate to protect one's health and protect everyone else's health, those who do not have access. And you as organizations are doing this. You're reaching those who do not have access or do not have knowledge on how to care for their health. Now, something else that religion promotes, which also goes to vaccination, is the mandate to help your neighbor. Let us say that we fully understand that we need to protect health and that vaccination based on common sense and scientific knowledge, then it becomes a religious mandate. But this is not enough. We need another mandate so that we can mobilize to help those. And we see the statistics, those who do not have access to health or vaccination. The world is programmed in such a way that we all need to help one another. As the Bible says, poverty will never disappear from the face of the earth. So this is why God mandates that we must help one another. And there are those that have problems with access for better health. But it is a religious duty, not only to protect my health. I understand that as a divine mandate, but there's also the mandate to help my neighbor so that my neighbor can enjoy good health and be vaccinated in a hygienic environment, to give sense to life, something precious, something in the image of God. Every human being is a world. We need to protect our lives and the lives of others. And from a religious perspective, we need to listen to science when it comes to health. And second, we need to make sure that those who do not have access can have it. Now, the third important religious element is understanding. Let us say that I believe I need to care for myself, I need to be vaccinated, I need to help my neighbor, but we need to be prepared. We need to convince, we need to have convincing arguments. Those who may have a certain skepticism about what I say. Now, the person will often ask, why does this person want to help me? And maybe this is an accusation. One can always be skeptical. Now, to counter this, we need to, from a religious perspective, we cannot talk about something we do not understand. It's not a question of faith. It's a question of understanding in order to communicate to someone else who has suspicions about our interests. And lastly, we have the question in religion. In one of our prayers for Yom Kippur, we say that a day will come when we are all a community of human beings without divisions into sects and groups, political divisiveness in beliefs, ideas, groups, means that when one says something, the other group then automatically, without thinking about it, goes against it. So this in turn means that there's a predisposition to go against everything that the other says, even if it's true. So let's think of Maimonides again. He said something very important. The truth comes from whoever says it. It isn't matter if it's someone who belongs to my group or my religion or not. We must, when it comes to health, end political divisiveness, putting into danger our neighbors, our citizens on the planet. So to sum up, there are 4 questions from a religious perspective that mandate us to care for health. And we see vaccination as a fundamental element for preventing disease. And first, we need to understand that health is a mandate. It's a God-given mandate. Now, what God most desires is for us to protect life. Now, there are those who say, I trust in God, but we need to protect our own health and we need to protect the health of others. We need to protect those who do not have the means to protect their health. And the third mandate is understanding science with scientific evidence, the importance of vaccination. Otherwise, we will not be able to help others. So we need to have a scientific foundation. And the fourth is coming together. This is also an appeal from God, not because one political party or another has a certain attitude regarding vaccination. Do we need to go against that immediately? We need to remember God's call to all human beings that we're children of a creator and we're all looking to help one another. So I think these are important thoughts to be shared at this very valuable event, at this very timely event for this part of our world, for the entire world. We need to care for the life of others, and we certainly wish that all these organizations, communities, parents, all of you protect health. And I thank you for this opportunity, which is so important. Protecting life. And may we all be inspired to continue to protect the health of all human beings.
Thank you very much, Grand Rabbi, for your very worthwhile remarks. And I certainly hope that everyone listening and will reflect on your words and take them into consideration. Now, Reverend Harold Segura, Director of Faith and Development of World Vision, Latin America and the Caribbean. Reverend Harold Segura is going to tell us how faith-based actors and religions can help encourage people to become vaccinated. I would also remind you that you've got Q&A. You can also put your questions into the chat or the Q&A. Thank you, Maite, and I thank the organizers for this event. I thank you very much for your invitation, and I greet Dr. Daniel Salas as a Colombian who resides in Costa Rica, having gone through the pandemic while he was the health minister. We owe you much, Dr. Salas. I admire you and I respect you, and I'm very grateful for what you've did. Now, the topic assigned to me is how religions can collaborate to promote vaccination. I thank the Grand Rabbi for his presentation. I think that he has laid the groundwork, and I agree with him 100%, and that will help me with my presentation. Let me start by telling you an anecdote, something I read a few years back. This was a Jesuit psychotherapist, priest, born in India, where he was a religious leader for many years and who was an active promoter of a dialogue across religions in his country. And the anecdote goes as follows. A day in which the wind was blowing very strong, someone parachuter jumped out of a plane, and he was blown off course, and he landed 100 miles away from where he wanted to land, and his parachute, lucky for him, became entangled in a tree, and he hung from that tree, and for a number of hours he was calling out for help. He didn't know where he was, and eventually someone walked by under him and said, "What are you doing up there in the tree?" And so the parachuter told him what had happened, and then asked, "Can you tell me where I am?" "In a tree," the other gentleman on the ground said to him. "You must be a cleric." And the other was surprised. "Yes, I am." "But how did you know?" "Because what you said is true, but it doesn't mean no good." Now, when we think of faith actors as promoters of vaccination, sometimes we are trying to answer the question within this unique context of the Caribbean and Latin America, that is, what good does faith do in a situation like this? And so we are asking about the practical efficacy of our faiths, in the plural, faiths, especially in a region in which faith tends to be identified with speeches, doctrines, theologies, rites, but not much with people's daily lives, society's daily lives. Now, promoting vaccines as a means of reducing the risk to exposure to COVID-19 offers us the opportunity of faith workers to practice love of our fellows and self-love. COVID has challenged our way of expressing that love in an effective way. We're speaking about the efficacy of love. This is the love that ultimately we preach in all of our religions, faiths, and different forms of spirituality. And so the question is how to put that love into practice as promoters of vaccinations. What I'm going to say next comes from a very positive experience that the organization I work for has gone through, World Vision for Latin America and the Caribbean, and I'm going to also try to include here some of the work that we've done outside of our region, working with faith workers in Asia, Africa, Eastern Europe as well, Latin America, mostly with evangelicals and Catholics. So just by way of summary, for starters, we have promoted some things that we think have been effective. Faith leaders and actors are called upon to set the model, set the example of getting the vaccines by ourselves becoming fully vaccinated. And we've carried out this campaign throughout Latin America to engage evangelical leaders, Catholic leaders, and others to, from their own experiences, serve as an example to their followers to drive home the urgency and the importance of becoming vaccinated, and to promote throughout community vaccination as an expression of our faith, love for life, and taking on the responsibility of protecting others, our brethren, as a part of our of what we preach as Christians, evangelical Christians, to work with government bodies and other institutions to promote actively vaccinations and to get faith communities to come on board to what governments and other organizations are doing by way of vaccinating people. There have been very positive experiences throughout Latin America in which faith communities that were not very socially engaged or with their communities, but during the pandemic saw that promoting the vaccine was a great opportunity for them to make themselves present as faith actors in society at large. And they did so in a way that we found very gratifying. Now, to offer our places of religion, our headquarters, wherever possible, as centers for vaccination, and to work with the states to ensure that all people have access to vaccination. This is something that some countries have done better than others, in which faith actors and their communities have taken on that responsibility. Something else that's very important, and with this, I will conclude this introductory remark, and that is to offer truthful information about vaccinations, especially in those sectors where fake news dismisses the importance of vaccinations, sometimes even appealing to religious arguments and supposed alleged theological arguments, infodemia, as it's come to be called. Now, we have gathered up some of these experiences over the last couple of months, with which we have put together a program which we are promoting in Asia, Africa, Eastern Europe, and Latin America, a program which we call Channels of Hope for COVID vaccines. It's a program for which we have trained Buddhist teachers, imams, preachers, pastors. They receive information. This information is made available. They're trained during 10 or 15 hours in which they are given all of the basic information as we see it. And we spend a lot of time listening to them and to answer the questions that they bring to us from their communities for World Vision and other organizations here. This has been a priority for us to ensure the application of a full vaccination schedule with special attention to children, especially vulnerable children. Now, according to WHO guidelines, we have made a call to prioritize the full schedule of vaccination, especially for children, and we have also joined WHO to encourage the ongoing development of vaccines, especially, as I said in our case, thinking about boys, girls, adolescents, children, and young people to reduce the risk of spread of the vaccine. Something else that's also very important, which is for everyone, especially those living in the most vulnerable areas, to receive the full schedule of vaccinations, but that they also comply with all of the immunization requirements, prioritizing these vulnerable populations in all other countries. This has been our priority, and that is to get vaccine producers to step up their outreach. That is outreach we've carried out as faith workers vis-a-vis these vaccine producers. We urge them to make their vaccines available to the most vulnerable. We are fully aware that there are some people in faith communities that reject vaccines for them, for their children, and their loved ones, who themselves have questions about vaccines. And as I said from the beginning, oftentimes rooting their hesitancy in sacred texts. Those who promote this hesitancy or rejection sometimes themselves are faith promoters. And so we make a call. We stress upon them to understand that vaccines are something that can protect people. We in our project, Channels of Hope, have devoted an entire chapter on this. And so we have worked with other organizations on providing information, raising awareness, and mobilizing faith actors for vaccination. Now, from these experiences, some affirmations can be derived. Faith actors can be effective vaccination promoters, advocates. This is something we can do in our communities, using our influence in a positive way to help people, and also appealing to our own faith, as the Grand Rabbi has said, as principles to protect life, promoting life, protecting life. I really agree and liked what the Rabbi said. Life comes before religion. Now, during the pandemic, the investigations or research that has been done on the influence of faith-based organizations, that's been proven. And this is a community that has much influence throughout society, for evil or for good. And so faith actors took on this role as an expression of their love, and where this happened, the positive effect in society was quite great. Now, among the different faiths and beliefs, I use the plural. We need to create a community, a common ground across the faiths, from which we can promote and advocate vaccination. So our dialogue, simply for this purpose, simply becomes a dialogue for these agreements that we have cultivated for so many years, can turn into effective campaigns to advocate for vaccination. I'm referring to a common creed that includes love, solidarity, protection, care, that we can also share among Christians of all the different confessions and other religions as well, to assert the belief in one God, understood as love. I think all of the theologies agree in that. In speaking of God, what we can say is that God is love, and that love is a protective love. To protect life means to resist the opposite of life, which is death. Now, Apostle Paul in the New Testament said that death is your enemy. He said it very clearly in the hope that your enemy would be vanquished, but still an enemy. And we saw the very painful outlook of the pandemic, more than 6.5 million people who passed away. Faith expresses love to life, for life, at the same time that it rejects death. It rejects death in all of its expressions, promoting the means made available by science and medicine to protect life. Now, as the Prophet Allah said, none of you is a believer is insofar as you don't love for your brother what you love for yourself. And the Prophet went on to say, you will not go into paradise unless you are a believer, and you will not be a believer insofar as you don't love your fellow. And so this translates into promoting vaccination and to be promoted by faith actors. Another factor to bear in mind, and with this I will conclude on vaccines. Disinformation, misinformation, and the harm it does. And so this is another role that faith actors can play to offer guidance and truth. Given all of the fake news, oftentimes backed by false beliefs and religions, we as faith promoters can advocate for the truth, and we can adhere to practical guidelines. Faith actors can encourage their community to assess sources of information within this context of infodemia or excess information, and to compare and contrast information, to read beyond the headlines, sometimes that they most often find on social networks, and to identify the author of some of these of this news, to verify the date in which that news item was generated, to examine evidence, to look into your own preconceived notions and prejudices, not just saying, I like it on social networks. To check facts, to set an example, to carefully choose what you share, and in some cases, to also promote, to encourage that during the difficult time of lockdown, to get people to spend less time online, and to choose better the information they receive, or in the faith communities, for information that we're receiving to also be assessed. Now, Bible study groups that would meet weekly in our community, and that was an opportunity for us to take a look at all the information that the community was receiving. So faith actors can be effective advocates of vaccination, to ensure that information is accurate, up to date, beyond our particular beliefs. We do believe in love for life and promotion of and protection of people's lives in the community, in a sense of solidarity. So going back to what I said in the beginning, we are here to show that our faith can be helpful, and it should serve to protect lives. Thank you very much. Thank you, Reverend, for your thoughts. We're running a bit behind schedule. If you have any questions for any of our panelists, don't forget, you can put your questions in the Q&A or in the chat, and we are monitoring both of those, and we will get to your questions. Now, I give the floor to Ms. Isolda Fortin, who's a consultant. Isolda Fortin. She is going to tell us a little bit about the experience she's had in Guatemala, working directly with faith-based actors to encourage routine vaccination, as well as vaccination against COVID. And please share your screen. Thank you very much. I am going to share my screen right now. I'll put it in presentation mode. Can you see my full screen? Yes. Thank you. I would like to start by thanking PAHO and WHO for this very important initiative, and those who spoke before me as well, for contributing so much input for this analysis, for this discussion, very rich information, and we're especially grateful here at PAHO Guatemala for the opportunity you're giving us to share our experiences in Guatemala. I'm going to start with this presentation, which is based on an anthropological study that was conducted last year in our country, a large-scale study that generated very worthwhile results, some of which have already been addressed in some of the prior presentations. Now, in my presentation, you're going to see a brief context and description of the methodologies that we used, the most important results or outcomes, and the use of evidence in public health. So let's start talking about the context of the study, this wonderful country where I was born. It's a small country 46% of the population is rural, 44% of the population is indigenous, concentrated mostly in some departments as Alta Verapaz, Solola, Toton, Capan, Quiche, San Marcos. 25 different languages are spoken. Some of these languages don't have very many people left to speak them, but in our small country, we do have 25 languages, Spanish being the official language. We have 22 languages based on Maya and also Xinca and Garifuna. Now, add to the linguistic complexity, we have 150 variants of dialects tied to given communities. So we speak of Quiche, but there are variants of the Quiche language. Now, our country was originally mostly Catholic, but in the last century, the Protestant religions have grown. Christian evangelical churches have grown, and something else I would say that's very important, which is the affiliation to different churches is also quite complex because it crosses over and overlaps with linguistic and cultural aspects. And also there's a urban rural layer to that. 45% are Catholic, 42% are Protestant or evangelicals. These percentages vary according to the source of the information. The national COVID-19 vaccination plan was kicked off in February 2021, and we see that bilateral donations and purchases into our country, all of which were conducted through COVAX. With this chart, I'd like you to see that there was initially a high demand for vaccines, and then we saw that rollout of vaccination took place mostly in the cities, and the communication was done in Spanish with a Western cultural tone. And then we saw some hesitancy and rejection of the COVID-19 vaccine, vaccination services, and public health in general. Now, this is very strange because if public health services were called into question by the population, well, that just exacerbates concerns that people have about the COVID vaccines. So what we see here is that the first doses reached a certain level, certain percentage, and then the second dose, you'll see that that percentage of the second dose was lower. You see that in this chart. So again, the second dose was at a lower level than the first dose. Now, what are the main differences between rural and urban areas? There are countries in which there's greater populational density, more people living in cities, but as you see in Guatemala, many people still live in the countryside. A large percentage of the population does. But we see that among those needs that we have identified, we are going to see that we need to step up our vaccination ability at the community level. We have some communities that are far-flung, and it takes 4 to 5 hours to reach them, and we have to create certain guidelines for them. We've been working on that, and there are some success stories. I could just mention one by way of example. There's a PAHO program called Health on Wheels, working in one of these populations that are mostly indigenous, to large indigenous groups there, in which the exercise is to take health to these communities. And the investment has been quite hefty, but it's been successful. And creating a demand for vaccination in the rural areas, indigenous communities, and that's where we see how important it is for us to understand the cultural dynamic and the reality that indigenous people are experiencing. Now, how did we conduct this study? Mixed methodologies were used. We conducted interviews through intercultural healthcare liaisons that work in the communities, and we conducted through them these interviews. We also conducted interviews of those charged with providing the vaccinations, also working with traditional therapists, midwives. Surveys were done of the users, that is, the people who lived in those communities. That is, household surveys were conducted, and then we did something akin to a focal group. We took the information that we gathered and we assessed it, ran it by these people, and we tried with that to divine some details. This was very helpful for us to issue some recommendations for our reports. Now, the result or the product of these consultations led to 27 different reports. So we saw that in each population, we have specific groups that need to be treated in a very particular way, and that we had to identify influencers, people, community leaders that people believed in, with whom we could partner up for them to provide information and support us in the in setting a model for the community.
In addition, we needed to facilitate the delivery of messages, and this could also be modeled within the communities. The final report, we summarized the work being done in the country with recommendations by region. Now, the different elements taken into account in gathering and analyzing data. This was done simultaneously by several teams. And here you can see the map. The entire country was covered. We worked with 22 ethno-linguistic Mayan groups, both in urban and rural areas. Our teams were made up of anthropologists and sociologists, and they had local interpreters. And we also had interviews with N equal to 27 for the interviews, and for health personnel, N equal to 406, and for community levels, traditional healers and midwives, N 668. This was an important database. Now, as to the quantitative survey, we had 2,310 representatives from households and 67 analysis groups. And in the end, we had details on the more effective means of communication at a local level. And so I would like to comment on the following. Even though in some countries radio is not very important, in Guatemala, the use of radio is very important. And we don't always have a band that will cover the entire country. So we need to identify local radio stations. And this includes evangelical and Christian radio stations. And these religious radio stations are among the most important in the country. Now, the results from this study. Now, as to reluctance to vaccination, we see a great deal of variability among the different ethno-linguistic groups. Here we're going to see a graph on the right. And here you can see the Mayan population, which includes the 22 communities. And then we have the Mestizo Ladino community. We have the Garifunas and the Xinca. As you can see, among the Mayan population, there is greater reluctance than in other groups. Now, when we worked with the main 5 languages, this was an academic exercise. Here, the Maya Language Academy was very important. However, we always note a cultural barrier if the dialect of the person is not spoken. So it's very important to identify these different dialectical variants in order to transmit certain messages. And here, what's necessary is the support of local leaders, and their translations have been very valuable. Here, it's also important to mention that the authorities were not always facilitating communication campaigns with appropriate linguistic characteristics. And so this has been difficult. And as we note, to have the campaigns with dialectical variants could only be achieved at a 35% level in the different health areas. And when it comes to meeting with community leaders and authorities, less than 50% in the health areas were able to hold these meetings. Now, going more specifically into the main results. Now, when we talk about religion, and it's what we're dealing with today, we understand that religious leaders are a key because they are a model of attitudes and practices, especially when it comes to vaccination. People are seeking counsel and approval from their leaders in order to make a decision. Now, here we see something very interesting. We see, for instance, 27% of household representatives surveyed reporting that they believe in their religious leaders and that in their community, they do not seek vaccinations. This is what they believe should be their behavior. We have 28%. And here we also have very interesting information. 28% of the 67 religious leaders surveyed reported that they had insufficient information. So there are very few that feel that they have sufficient information, only 28%. And then what we mentioned before. Now, there's this conflict between vaccination and faith. So many believe that if one has faith, there's no need to have a vaccination. There were other verbal expressions that God will protect me and cure me if I am sick. And there was the other concept of losing one's soul for eternity if vaccinated. So much better to have a temporal sickness than to have the mark of the beast. And lastly, there's fear and mistrust regarding the vaccine. This uncertainty of not knowing what's going to happen. And we've heard all of these different myths that you're familiar with, that the vaccine causes death because it's a poison, it sterilizes it, it has a chip, you become a zombie. And so these have all been expressed. And lastly, the question of negative energy, which can be communicated to others. Now, when it comes to fear, there's a concern of one having the disease or one being contagious to a loved one. So there is a stronger concern when it comes to communicating the disease to others than to one being a victim. Now, the main results. What do we need to consider? What are the myths that we need to manage so that these are not spread? Well, first, that the vaccine kills, that it's a sign of the apocalypse. And here we have the work of the religious leaders, the models who can support us in helping us change these ideas. So what have we done with all of the information? We have more than 10 presentations. We have written publications. We've organized a number of campaigns, and we've also organized dialogues with ancestral authorities. We've done collaborative work with cultural leaders and with the Ministry of Health. We've also worked in communicating on vaccines with cultural leaders, both Maya, Xinca, and Garifuna. Now, there are other activities, specifically the involvement of religious leaders, and the Interreligious Council has been very important, a very important social actor providing much support. As the results were submitted, and thus we were supported in actions promoting vaccination. There's been coordination with the ministry and some of the religious leaders. The training of community and religious leaders at a local level on vaccination is very important. And as we already mentioned, the use of creating safe environments in churches, theaters, and making these available. We've also developed positive messaging, and this includes everything from developing joint messages with the religious leaders and using as a reference here, it's the New Testament, but it's also the Old Testament that also contains principles of public health. So all of this can be used in order to work on the messages, also to increase visibility so that one can see that there is a connection and that there is support and that there is a link between religious leaders and health workers, and also to use the important space in churches to be able to influence leaders and the community. Now we have a very exciting process ahead of us because we are going to launch. We are now concluding the design for implementation of a pilot workshop, and there will be involved religious leaders. It is a workshop with a human-centered design. So we use our research data to understand the population and the culture. Then we do a pilot study, we learn from that, and from that, we do broader implementation. Now, the pilot workshop will be taking place in November, mid-November. We are going to contract an interdenominational Christian group that focuses on leadership training and religious training. Now, the staff in charge of the workshop is highly trained. We're talking of those who have a doctorate in theology. We're talking of a physician belonging to the same organization, sharing all of these values and beliefs. And here we have a program which can, with the use of the Bible, stress the importance of caring for the body and the environment. We've also developed a number of other courses on health. This means that health is something that needs to be looked at from the point of view of the church. We're going to work with evangelical leaders as they represent a very high percentage. And as there are no central authorities, there's no hierarchical leadership. We've had to select religious leaders from the Department of Verapaz. And this will be the pilot department for the workshop. And we have certain criteria for selecting these religious leaders. There are many, but we can only deal with 57 at this time. So to select the leaders, we take into account the size of the church. It's not the church itself, but it's the members of the church. And this is proportional to the area covered by the church. And then we take into account the position of religious leaders regarding the vaccination. So we need to see who we can better select for the workshop. We need to see if they belong to some network, because in this way we can disseminate more information. And we need to know whether this leader is involved in health questions. Some leaders are more involved and others less. And the ones who are most involved will be most enthusiastic regarding the workshop. Now, the goal of the workshop is to encourage evangelical leaders to give value and to implement preventive health measures at an individual and a community level. We also see a biblical focus on health and the responsibility of caring for one's body and for the creation, the environment. So this also has to do with natural resources and the environment. And lastly, to mention that this workshop will be recorded and reviewed to see what the technical considerations would be to promote changes among religious leaders participating. We will also have an evaluation pre and post to establish which are the changes in knowledge and attitudes before considering replicating this workshop in other parts of the country. I will conclude by giving thanks, especially to all of the participants of the study who gave us their time to respond to our questions, to all of the health staff who needed to make room for this, even with their workload of recent years. And I would like to thank the entire research team, the PAHO team in Guatemala, and we are also giving thanks to those who financed us at WHO and Canada. Thank you very much, and I conclude. Thank you. Thank you, Isolda. That was a very interesting experience in Guatemala. I know I had promised Q&A, but given time restrictions and given that all of our panelists are very busy, we are going to conclude. And if you have any questions or comments or something very specific, please contact us, contact Pajo, and I will make sure that your question is appropriately channeled. So I will close, first of all, by thanking all of the panelists who have participated today and for giving us their time and for their messages. And Dr. Silas emphasized how important cooperation is among different faith-based leaders of different religions and how this is essential in terms of bringing communities together. We also wish to thank Elia Cizinki that vaccination is a human right and it is one of the goals of sustainable development. And offering thanks to Religiones por la Paz, and Lucia Oliveira also showed us what the situation is in the region, and the situation is quite alarming. But we understand that it's not just a question of numbers, but we're looking at children who are not protected, who could die and suffer very dangerous diseases. And this can be avoided with the vaccine. And it's also important to look at the local and national level to see where greater efforts are required, especially to reach the children in our communities. Now, the Grand Rabbi, Isaac Saka, talked to us about the perspective of religion and how we are mandated to care for our health, and how health is a divine mandate, and what God most seeks is that we care for our lives and care for our health. And we heard about how more information needs to be necessary. And thirdly, we need to understand how scientific evidence can be used, and that this is a message that needs to be communicated. And lastly, we heard about how we need to eliminate differences. Now, Reverend Segura also gave us some very concrete messages of how we can protect all lives and how to use theology, and how love, solidarity, and protection is part of the credo, and how we can encourage actions and persons and communities to use credible sources of information. Lastly, I would like to thank our colleagues of Guatemala for having shared their experiences. And they've certainly showed us how important it is to see what is happening in the country and how this evidence can be used for appropriate interventions, for mass communication and interventions, or how to involve different types of community actors, as Dr. Silas also mentioned when it comes to mutual understanding. We would also like to wish everyone on the pilot study the best. And then we want to hear about the results of your pilot studies and see if these can be replicated. Well, once again, I thank all of the panelists, and I know you have busy schedules. We have been very pleased to have you with us, and we hope that this will be the beginning of a very close collaboration with Pajo, and that we will involve even more religious leaders and how we can benefit both religion and public health. I would also like to thank the interpreters and the technical staff who have assisted us. And after 2 years of a pandemic, we still have some technical problems, but we seem to have resolved them. I would like to thank all of the participants for having heard these messages, and we hope that they will help you and your work in your communities. And we also hope that our PAHO colleagues will be able to participate more and more with religious leaders. We will be sharing the recordings in the 4 languages for which we have interpretation, and we will also have a brief summary of the presentations of the key points heard today. And as I mentioned, if you have any questions, please write us and we will either channel your question to a panelist or answer it. So with this, once again, thank you for your participation, and we hope to meet soon again. Thank you. Thank you. I guess we're all running to whatever our next commitment is.